Welcome back, everybody, to the Functional Code. We are excited to bring you guys today a new episode. We are going to be doing a core episode on extremities. This is where we dive into one of our recent pods, and we just take the gems, the essentials only. And we're going to be talking wrists, elbows, ankles, and feet. I am Dr. Addy.
And I am Dr. Jace. We'll throw a little bit of knee in there too, if we did not say. But yeah, we're going to look at everything in terms of tissue structure, some joint work, a little bit of blood flow, nervous system regulation as well. And we're going to dive right into it as we go through. A couple small things in terms of stuff that we talked on previous episodes. Evolution is a huge, key, important factor. We can dive more into that there, but in terms of how the body adapted over thousands and hundreds of thousands of years, there's a way and there's a reason why we have the structure we have. Some of it's pros, some of it's cons.
Yeah.
But when we're looking at whether it's computer work, typing with our hands, wrists, forearms, or whether it's sedentary lifestyles and not building up our feet structure, our gait, and how we walk and how we move, all that is bled into either lack of function, injury, pain, or it's the opposite of some of the strengths that you can find yourself in of having a huge foundation to grow and build upon on that side of things.
I like this phrase here. Your hands and feet aren't just endpoints, they're functional launch pads.
Ooh.
I love that. And not only that, they're an incredible sensory component to the brain's mapping system.
Well stated.
And the only way to build that map to make it more clear for the brain is to use and stimulate the end distal points, and that'd be the hands and feet, obviously. But too many times, I think we just don't either move enough or do enough to create more of that stimulation. And so over time, we lose the ability to feel in certain parts of the feet, and we start to get breakdown in the joints, what have you. And I think it's happening at an earlier age than maybe what we're used to. Feet especially. How many people have such poor pronation or just foot structure in general, bunions? And you're seeing that in their 20s and 30s now. And I think that's starting to get a little scary, especially with just the health of individuals getting worse earlier on in life. But Doc, I think one of the more common things, we'll start with the upper extremities, move into the lower extremities, but tennis elbow has to be probably one of the more common things that we see when it comes to extremity issues. What do you think is really going on, and what can people do to improve that issue?
And let's throw tennis elbow, golfer's elbow.
Yeah, for sure.
Let's throw that in there. But no, that's good. That's a good point. So usually with golfer's elbow, tennis elbow, it's where there's consistent tension pain on the outside or inside portion of the elbow. Usually, most common overuse type of movements, especially if the tissues around the area aren't built up over periods of time. And then it can lead to compensations down from there. A good test if you want to find out whether you're a golfer or a tennis advocate would be put your arm out in front of you. Does it deviate off to the side? If so, you probably have a potential injury coming down the road, or you still have an injury from previously. Or if you're just completely double jointed where the elbow, the forearm goes back behind in the forearm, upper arm, humerus. So if your arm does come outwards here, you'd want rotational movement as you're going back and forth into flexion and extension, or vice versa. Mindful and specific types of movement from one side off to the other, which involves a little bit of the shoulder, so you might have to stabilize that and get into more like a deviation of the wrist. But all of that, it bleeds into building up the whole area, if we will, on that side. So, Doc, there's some potential myths that can come about this in terms of with overuse injuries from gripping. Does some of those play into, does the gripping actually cause a lot of the issues for tennis and golfers out there?
Gripping was the stimulus that caused it, but the problem was we didn't have prepared tissue. The tissue was either unprepared, unconditioned, or it was injured and you didn't heal it appropriately after you had the injury. So there's less facilitation, there's less stability, and the stimulus of gripping or overuse then caused it to get worse. A lot of the times too with tennis elbow, you have either breakdown of the chain, which is up the chain would be the shoulder. There's poor shoulder mechanics. A lot of the people that injure either the elbow or the wrist start getting shoulder pain just because we see this compensatory change. And same here. We get a lot of shoulder issues. We tend to get more elbow pain or neck pain, just again with the compensatory change around the joint. So I think there's a lot more that goes into it than people understand. And the last thing that I actually have seen in research is the compression of the radial nerve can be a strong tie to referred pain to the elbow. And that is actually missed a lot. So I wanted to say it was over 50% showed that there was at least compression in one area of patients that had tennis elbow. Now, whether that was just a part of the issue, not the entire issue, it's tough to take all the variables away, but looking at more of this as a nerve issue too can also be helpful if you're not seeing the results you want from like a PT kind of focused training either. There's a lot to it, and there's always going to be a lot to it, and I think that's what people miss is they want to do this one-to-one thing where one thing causes it, one thing fixes it, and again, that's just not going to be the case. There's a lot more that they can do. So Doc, from a standpoint of, let's say it is more structural, more tendon issue, what's the fix? What should they start doing to at least get some change? Maybe not completely fix it, but where can they get started?
I would say specifically for most any tissue, you'd want isometric contraction. It's how you'd start most any rehab process in itself. If you have someone helping you, but you're not necessarily getting the results, there's probably certain steps that they may have missed, and then overlying compensation usually comes from there. So ideally, arm close or arm bent, a bicep curl, stimulate, you would want to force a contraction here, isometric contraction, and then with your arm completely straight, same thing, isometric contraction. Now you can add in to where you deviate your palm inwards, closer to your body, same thing, squeeze, or outwards, same thing, squeeze. All of this is bleeding into a lot of the connective tissue, ligaments, tendons, some of the joint capsule as well, but more or less we activate at length, or we go from short to long, or to length would be the other aspect. So whether it's bending our elbow, bending our wrist, and then extending both, which can get into a little bit of a nerve flossing aspect as well. But you would ideally want to start, like I said, isometrics, and then build up from there and go in short to long, eccentrically wise. Anytime you go straight to eccentrics or loading or lengthening, that creates friction between layers of muscle bellies, and that's where you'd want to make sure that you start the rehab process to diminish the inflammatory response for the injured tissue. Once that builds up, the range of motion increases, a little less pain, then you can get into these lengthening type of movements from there.
And an elbow strap can be a good short-term advantage to improving the function, reducing the strain on the injured tissue. Those are pretty cheap on Amazon. I think those tend to be the most effective in the short term for a lot of patients who have tennis elbow, but it's not your fix. And you got to remember that it's a Band-Aid, right?
Yes.
Eventually you still need to train and prepare those tendons, heal them up so that you can do proper grip and function with the arm. But again, I think it's a way to reduce strain on the already inflamed tendon, give it some time to rest and heal, and then eventually you can work it once, give it some time. So
I love you brought that up.
How about carpal tunnel? So we're moving more down to the wrist. This is one of the more common wrist issues. I think we definitely don't want to forget about how wrist pain can also be coming from the neck. Carpal tunnel is often misdiagnosed, but let's say for most people who, let's say you have true carpal tunnel, where is the issue and what are they looking to improve? What are they looking to make a difference?
Yeah, most of the times it's nerve entrapment of either local site or it's coming from a connection where the pretty much it comes out of the brain stem, spinal cord, and then out to the body, which if there's any compression, it can have these similar mimicking symptoms. Even if they do a nerve conduction velocity test or NCV to see what the strength of the nerve is, which is a very painful test.
Yeah.
They have to do that in terms of steps to diagnose, but to even have carpal tunnel surgery in the first place. Sometimes that test can be misdiagnosed as well. And again, I'm not a neurologist, I'm not a surgeon, but we see these types of symptoms coming into our clinic. They've had these tests done, they've tested positive, and they still have the pain after the surgery.
Yes.
They still have pain after the types of treatments. And we go through a trial of care, correcting the neck, and then also doing some muscle stuff in terms of down the chain, forearms, hands, and then the pain's gone, just like that. It's like there's certain things that can be missing even with definitive quotation tests. But yeah, a lot of it is nerve compression, either due to the tissues locally or upstream from the neck on down. Even oftentimes in the armpit can have similar symptoms as well on that side. Doc, with wrists, how well do chiropractic or manipulation adjustments help with carpal tunnel?
For sure. And I actually want quickly to point out the difference between maybe one or two different things that you'll experience more on the wrist. So
love that.
We have most of the time, I like to think of three numbnesses that can happen. First numbness is these three fingers right here, okay? That is the median nerve.
Your thumb, pointer,
thumb,
and middle.
pointer, and middle,
Yep.
okay? That is the median nerve, and that runs through the carpal tunnel in the wrist, which is what we've been talking about. Now, when we have compression, that's where we're going to start to feel symptoms, numbness, tingling. Even sometimes if it gets really bad, you'll start to get weakness of those and atrophy of the muscle on the thumb right here, okay? And that's when it's gotten really bad. Then we have these outer two, just these outer two that are numb and tingly. Now, that's not carpal tunnel. That is cubital tunnel, and that's actually up by the elbow here. And that it can be compressed, whether you've been putting your elbows on a desk for too long. Sometimes it's down on just below it on the forearms. That can sometimes change the compression in the ulnar nerve, and that's where we're getting that. And then the last is your whole hand is numb. Now that could also more be likely coming from the neck. Compression or radiculopathy coming from the neck. It can also come from some types of axillary compression too, or like TOS symptomology in the brachial plexus. But you need to understand the difference between the three, because a lot of the times, if you go in with whole hand numbness and they say it's carpal tunnel, you should already have your red flags up and say, okay, no, that's not true. We need to think about this differently, because if they're just trying to get you to do surgery and they're not even doing a full exam on you, or they don't even understand their basic anatomy, that's concerning. And believe it or not, people, it has happened. We have seen these
more than you think.
And it's sad. It's really sad to go through this surgery and give people hope, and then they get out of surgery and they have this pain still. It's frustrating. So now back to your original question, does chiropractic help? Absolutely. When we have the ability to manipulate the wrist, to manipulate the small bones in the hands, especially around where the carpal tunnel is, there's a better ability for that nerve to exist in its space, especially if there was compression. Nerve flossing in itself can be helpful to improve the space and the kind of the nerve, we'll call it flow. And of course, just the amount of stimulation that chiropractic does to the joint, mechanoreceptors, proprioceptors, also does a kind of feedback loop to the brain, drives pain down, improves motion, a lot of other things that are really helpful for joint and pain. But yes, I think there are other things that go along with carpal tunnel. And if you treat carpal tunnel as more of a whole chain than just a local, I think you're going to get better results no matter what.
Well stated.
Yeah, working down the chain, even though you're having more wrist issues. So getting your neck adjusted, getting shoulder work done, getting elbow work done, wrist and forearm work done, along with doing hand exercises and things like that, your chance of not, missing carpal tunnel then improves because you're working the whole chain. If patients do have carpal tunnel, I'm going to be working their neck anyway.
Yes.
Because I just know down the line we're giving more information, and I think it's just going to improve it no matter what.
Yeah, nerve flow
Yeah.
for a healing rate makes a lot of sense as well.
Yeah.
And I think even for people that are typing on the computers more times than not, if you start working extensor muscles or bring your wrist into extension backwards, even if you lengthen your arm and bring your arm backwards and add in rotational work, that'll clear up a lot of the
I love
symptoms
that
as
one.
well.
I do that all the time.
Yeah, no, it's,
Yeah, I'm doing
like
that
3 for 1
legit
kind
all
of deal.
day. I love that one.
Then you can get into like nerve flossing as well, whether it's doing upside down eyeglasses or you're tilting your hand wrist at the same side as your head. All those can help significantly as well. Floss out and create tension on the nerve so you don't have as much guarding on the tissues surrounding it.
Super helpful.
Yeah, that would be a few different things, even going into the wrist workspace, wrist cars, or even tractioning out the fingers and adding a little rotational work.
All this is stimulation to the
Yes.
brain. And the brain, once it has the ability to see what's going on, whether there was a breakdown from injury or a lack of nerve conduction flow, all of it's going to make a difference. And so the hands are have vast amounts of receptors in them. And so being able to stimulate all of it, not just the area around the carpal tunnel, is only going to benefit you in the long run.
And I think I think in this distal extremity episode, I think a huge thing that most people, going back to Dr. Addy's point, that they don't realize is the dexterity and the neural input that you just said, and train that. So whether it's juggling, whether it's bouncing a ball off the wall, whether it's bringing your thumb to your pinky and to
Yes.
all the other fingers and working on the dexterity. One helps for cognitive recall, helps prevent to a certain extent like Alzheimer's and cognitive delay types of conditions, but also it builds up the small tissues around your whole arm body itself.
And we know how important grip strength is with our past podcasts as a marker for
Yes.
longevity in our older years. Having strong, good, healthy grip strength can be huge to tracking whether or not you have a decreased risk of death, all-cause mortality, all these other things that we measured. They've measured over time. Then these studies had over 10,000 people in them. Wow. And I remember seeing, and even in midlife, tracking in men showed a decreased grip strength was associated in early death in men if you were tracking grip strength in their midlife. So we're not just saying this because we want to sound cool. We're saying this because it has a huge tie to a lot of the things that we talk about. And working these things is important. And I know a lot of the times you think you don't have enough time, but we're trying to give you small, simple tools that doesn't take a lot of time that you can do to improve these areas of your life.
Even just scheduling these out on your calendar, maybe this week, one session that you want to work on dexterity of your fingers and toes.
Yep.
I would say maybe once every other week, once every third week, even once a month can help significantly if you have the focus on this stuff.
I had a colleague of mine who, one of his goals outside of training was to improve his ability to open and, I guess, adduct his toes.
Oh, sure.
And it took him 6 months before he even was able to, because one of his feet, he could do that really well with his toes. But he had nothing on his other side.
Wow.
And so I'm not sure how that happened, but he started with just his pinky toe, and then he started with his big toe, and then he'd pin down other toes and then work the third or fourth digit. And then eventually you could see after 6 months, it wasn't perfect, but he actually was able to do it by himself, retraining motor unit involvement. What that did though, finally, once he was able to get good movement of the toes, he said his toe flexor strength increased immensely and his squat improved really well. And he didn't change anything. He was just trying to improve that. So improving your grip strength, again, gives you endurance to lift more. It gives you endurance to do more things, and eventually it does make a difference.
I love that.
Yeah.
It's so important for every facet in life. Yeah, I think you touch on it that all day long, but yeah, those small muscles are so important, especially the brain's connection down. And in terms of the brain's real estate, a lot of it is going back to the hands and feet itself.
It is.
So the more you can train those,
that's why hand-eye coordination is a thing, because when you talk about the homunculus, which is the mapping structure of the brain, the eyes and the hands are right next to each other in the homunculus, and they take up a lot of real estate, especially when it comes to the feet too. And there's a reason for that. There is a reason for that. Sensory landmarks. These are sensory landmarks, and we need to continue to stimulate them. So, Doc, let's go to the lower extremities.
Love it.
When we're talking about the feet, ankles, plantar's fasciitis, Achilles tendinopathy probably are the most two common. Let's start with plantar's fasciitis. What is the plantar fascia? Why is it important? What is usually a common cause of breakdown? What is that? What is all that about?
Plantar fascia is the muscles and layers of muscles on the bottom of the feet. There's really 3 different types of layers, and then there's different types of arches as well. So there's a medial arch, there's a lateral arch, and then there's a transverse arch. So going back to the point you made with that patient trying to grip the ground or bring the toes together and apart, a lot of that is helping for the transverse arch and for some of the small connective tissue between each of the metatarsals, if we will. So going through and building up that strength and just the brain's connection down automatically release a lot of the muscle guarding. It also helps prevent any other detrimental issues down to the feet, especially if there's bone spurs or tenting off of the heel, whether it's the heel and or Achilles tendon in the back of the heel. That kind of works as a push-pulley mechanism, because usually if you have plantar fasciitis, usually there's a very high chance of an ankle Achilles strain, more because the heel calcaneus gets gripped down, almost pulled inwards, either rocked down or rocked up, depending on some of the other bone structures at the bottom of the feet, that then puts excessive load and pressure on the heel tendon itself. So those kind of work hand in hand to a certain extent on that side. And
I would say a lot of the times you're going to see breakdown in the biomechanics of the foot when patients who have plantar fasciitis.
Well stated.
For me, a couple gems that I've always picked up throughout the years tends to be posterior tibialis is weak. I see that a lot. It's known as the foot strap muscle because of how Doc will show what that looks like. But so with tibialis posterior, you see how it goes behind the inside of the ankle, but it attaches onto the medial arch. And when that muscle is strong, it allows for the arch to stay suspended. And when we don't have good posterior tibialis strength, that medial arch tends to collapse much quicker, in my opinion. And I'm sure there's research that ties to it, but really what I'm finding is patients who have plantar fasciitis tend to have more pronation. They probably have more arch breakdown. There's usually weakness in certain tissues, one of them being posterior tibialis when I'm testing it. So that is one thing that I'm already working on with them right away, is to improve the strength of posterior tibialis to get better arch suspension, get better strength in the foot, ultimately taking stress off of the bottom of the foot when it comes to how we walk, because when we have a flatter foot, we tend to be more predisposed to getting plantar fasciitis just from the biomechanics of the feet. Doc, when it comes to, I know with your things that you do with patients, I know one of the things you add in quickly is toe spacers.
Yes.
Do you want to talk a little bit about that too?
Yes, so important. Anytime there's a foot condition, oftentimes there's a miscommunication between brain and tissues. Like, I'd suggest anyone right now, put your foot on a surface, doesn't matter where, try to lift up just your pinky toe. Try to lift up just your big toe separate from all your other 4 toes. Or vice versa, put pressure of your big toe down to the ground, lift your outside 4 toes up. If you can't do any or all of those, there is either atrophy of the muscles, break down the muscles, or there's a disconnect. So adding in the toe separators, there's a few different ways that goes about it. One, it forces the mind and attention at that local area itself, because you have to put on the toe spacers, which takes a couple minutes in itself, and then going into like active motion and in terms of that connection, then you start going through very specific exercises, almost just like I said, trying to bring your big toe up, outside 4 toes down, big toe down, outside 4 toes up. So we're increasing the connection, going back to the motor units we spoke on previous episodes. We build up that connection. We help with the lumbricals and some of the small tissues between each of the metatarsals, which opens up the base of your foot, which allows for less compensation to the inside or outside the foot from there. So it creates a bigger foundation. It almost creates a little bit of a wider foot, which for certain athletes, sprinters specifically, can be a little bit of a detriment in terms of max speed. There's a fine line between a wide base foot and a foot that's a little bit more narrow just due to speed biomechanics. I still would suggest on the off time to build up that structure, even if you are a world-class sprinter, prevent injury from there. But the reason for the toe spares, like I said, brain's connection, build up the small tissues, and then the awareness factor.
For sure. So what's one way that you start helping plantar fascia that you think makes a good movement in the needle?
I think it would be any of those small things. Then also, and some of this goes back to the Achilles tendinopathy, longer lengthening or going to a calf raise and then slowly lowering your heel down to the ground. Ideally, you want your foot to be on a little bit of a surface so you can extend past 90 degrees and then hang out the bottom for a second. Add in different lines of rotation. Because going back to the screen here, there's a lot of muscles that start from the calf deeper and then more superficial and then go down to the outside part of the ankle and then attach to the top bottom of the foot. So we add in different angles and lowering. It lengthens a lot of these tendons that can create a lot of muscle guarding, which then attach to the bottom of the foot. So you've killed two birds with one stone.
Beautiful. I love that. And I think what you were talking about, was it Alfredson's protocol?
Yep.
Yeah.
Alfredson's.
Which is an easy way to Google if you have questions too. We touched a little bit on Achilles tendinopathy. Obviously, Doc, you said comes down, it attaches into the fascia. It can be, these two can be tied together.
Yes.
What are some misconceptions that you think, maybe not so much that, but maybe this is a better way of me phrasing it, is where do people see a breakdown in the Achilles and why are they continuing to see issues with it moving forward?
I think if there's a problem with the Achilles, it can either start at the knee or it can start at the heel or plantar fascia, kind of like what we talked about. As you can see, some of the calf muscles attached to the femur are above the knee joint, and oftentimes if there's any strains there, or if you're an older individual, more sedentary, you're going to start noticing some muscle tightness guarding on the inside or the back of the knee joint itself, which oftentimes if those muscles aren't worked, they will atrophy and they'll almost turn into like fatty deposits in that space until you build up the metabolism and the whole structure itself. And then it weakens the tendon where all these muscles attach to. And then if you are already having atrophy or breakdown of the muscle belly, just imagine the tendons and the ligaments around the area. It's just inevitable for fraying, tendinosis. Other feet problems usually come from the tendinopathy for the Achilles itself, but you start having problems up the chain from there, lower back stuff. It's just, it affects every type of movement, because if you're not able to dorsiflect or bring your toes up to your shins or plantar flex and pointing your toes down to the ground, if there's limitations with either of those, especially toes up to your body, it's going to affect gait cycle, how you walk. And I know, Doc, you've done so much training with that. Do you often see that with people that need gait training?
I say if you cannot dorsiflex, your chance of tearing that Achilles increases. I think it's 2 or 4-fold. I can't remember what the research shows, but it's a lot. And it's just because you are changing the way the biomechanics of the heel should go. And basically what's happening is how the toe off should allow for a proper gait function. When we don't have that, we tend to plant more and we tend to roll off the first metatarsal to get around our ability to dorsiflex. But that planting puts a lot of force into the Achilles musculotendinal junction area. And then, of course, it's putting a lot of force on the front first metatarsal here, which is why we have bunions, which we're about to get into, hallux valgus, and plantar fascia issues as well. So that whole kind of concept does bring about a lot of conditions that are all tied together just with how we walk. And a lot of people do this, and if you even watch people walk, they have a more externally rotated foot and they're rolling off the outside of their feet when they're walking. Yeah, for sure. And over time, it's just putting more stress onto the Achilles. It's putting more stress onto the plantar fascia and the first metatarsal. And you're going to get just, it's poor foot mechanics. You're going to get a lot more feet pain. It's going to cause more issues down the road. That's one of the more common gait issues I see.
So going back to the bunions, where are certain ways when you first hear or see a bunion, and maybe there's other problems with the knees, lower back, up the chain, what are some of the things that you start thinking about in terms of how to treat or start to address bunions in itself?
For sure. So what we're talking about is really how I would want to address a bunion is to make sure it doesn't form.
Yes.
And so when we start to see the big toe starting to move more laterally, or it starts to maybe fold inward towards your other toes, that's already a sign of biomechanical change that we're not excited about. Toe spacers, like Doc said, is a great way to start, making sure that we keep that big toe more midline towards the middle of your body and away from all the other toes. That's going to stop this joint from starting to wear out, start to swell, get bigger, and that's really what a bunion is. It's this calloused formation around the first metatarsal because of the way that your biomechanics have got to. Now, looking up the chain, you're thinking, okay, strength of the foot flexors, you're thinking Achilles, you're thinking knee, you're thinking hip, you're going all the way up. And what you're really ultimately looking at is how you're walking gait-wise. So when you are already seeing yourself having this externally rotated foot rolling off of the front of the first metatarsal, you're going to start to see already a wear and tear of this joint. How it should be is when you plant the heel, you should have good dorsiflexion and you should have good first toe flexion so that you can extend off the big toe and ultimately create a full gait cycle. And that is going to be really what you're shooting for. So there's a lot that you can look into this, but really what I'm looking for is, okay, number one, we need to remove the poor gait and insult to that big toe and heel and foot that you're creating. And then we need to create more strength into the certain areas of the toes, big toe especially, and then even the little muscles in the toes, the arch, which would be the posterior tibialis, which we've talked about, loosening the tension maybe into the plantar fascia, doing more work there, and then ultimately either strengthening the calves because they're weak and tight, or just improving dorsiflexion at the heel, whether that's reducing the tightness of the calf. But most of the time the calf is tight just because it's weak. It's not so much because, that's the concept you need to think about. Loading the calf, like Doc talked about with Alfredson's protocol, that's where we're going to see a great change in dorsiflexion. And that's just, again, just a part two of what's going on. So is it just always one thing? No, there's always going to be more than one thing that's going on, and that's really what I want people to understand. So, Doc, is there anything that you also look at when it comes to bunions that I'm missing?
I would say you can add in like some tools of self-mobilization.
Okay.
So let's say you take your socks, your shoes off at the end of the day, you're sitting on the ground. You can go through light mobilization, ideally
Nice.
with a little bit of like long axis traction, or you're pulling away from the joint and adding a little rotation, or you flex your toes to your body and vice versa, so you can get a little bit of a roll on the midfoot. That would be one of the big things. Now let's say it's bunion specifically. You would want to then hold long axis traction and then work the opposite way from the toe that it's coming inwards to outwards. And ideally, if you're able to have or hold like an exercise band, if you guys are watching the video, on the thumbs mimicking big toes, holding the resistance and then working into on your toes and then back down. So you almost even go into Alfredson's protocol with long axis traction as the joint is in a proper, less compromised position. Will also build up the tissues as well.
I like that.
I like the self-mobilization.
I like that.
So.
I like that a lot. So back to the knee, I think is where we'll end here. I like to think of it as a dumb joint. I really do. I think that the joint itself doesn't require, it's really in one plane. Yes, it's multiplanar, but it's not as much degrees as other joints. And so it's more of a stable joint than a mobile joint. But I find that most of the time when patients have knee pain, unless they had a true injury to that area and it was compromised, whether that was a meniscus tear or ligament tear, that something like that, a lot of the times I feel that it's coming from an improper force distribution, either from the ankle or from the hip.
Yes.
Do you find that to be similar?
Yeah. Elbows and knees are so similar. Like you said, problems coming from wrist, shoulder, or like you said, foot, hip from there.
Yeah.
Yeah.
Now with the knee, where does your exam start? What do you try to start looking for right away?
Yeah. Look at going back to the hip, foot. I start there. I also look at what rotational movement does the knee able to move. So passive, someone moving your limb versus an active, you're actually moving it. Passively, as I'm going and bending your knee, let's say you're on your back, this is an exam, I see how well the tib, fib, the bottom bones of your shin move as rotation work. If there's a limitation or restriction moving one way versus the other, I look either the bottom of the foot or to like the hamstrings. Sometimes can be quads or the muscles in the front of the thigh, but most often than not, the muscles of the hamstring, some of them attach to the inside, some of them one attaches to the outside. Those can usually be tight and tense and can compromise and affect rotational movement of the knee. And then you want to start thinking pelvis, glutes, hamstrings, and its involvement down to the knee from there.
Yeah.
So that's usually a first starting spot. You'd also want to see, is it acute versus a chronic injury? If it's acute, is there ligament damage? Is there tendon damage to a certain extent? Is there swelling, warmth around the area? So you can get a good idea in terms of tissue damage, potential tissue damage, and then go from there on that side. Is there anything that
That's exactly what I do. I make sure that I'm assessing above and below the knee. I'm also making sure that I'm assessing the knee itself for any inconsistencies of tissue. But I would say most of the time, the breakdown or the weakness is coming from hip or ankle, not so much knee. And I show that to patients. I'll have them contract either their quad or their hamstrings, and I test against that. And it's usually locked nice and tight. They have good strength. Then I'll go and test the tissues in the hip, and it's already a breakdown. There's weakness, there's less facilitation, and they're like, oh, whoa. So I said, okay, if you're having knee pain, but your knee was strong when I tested it, but your hip is weak, where do you think the breakdown is? And then they're like, oh, it's the hip. And I'm trying to get more people to understand that, where, yes, if you did have an insult to the knee, more than likely we have that to focus on too. But if you haven't had any real issues with your knee and you just started getting knee pain, start thinking above and below, and start trying to think of it in that perspective. There's probably some other things we could dive into maybe later with the knee regarding full ACL, meniscus rehab, those kinds of things too.
Yeah.
But it really, if you've been listening to us long enough, the knee is going to, every way we train is going to be similar as far as foundation. So making sure that you regain full range of motion, we're loading it properly, and then of course advancing that way. But that was the knee in a nutshell. Doc, is there anything else you want to add?
No, I think that was good. Yeah, starting even with rotational movement. This is where knowing how the nervous system communicates to the body and body back to the brain. Rotation being most of the main movements, especially ball and socket joints, most synovial joints. That adds in also with the knee.
Yeah. We
start thinking rotation of the knee to where you pretty much plant or not move your femur, and the only thing moving is your foot. So gets some bottom aspects of rotation from bottom up to the knee. That will subsequently help for a lot of the small tissues behind the base of the knee, some of the calves, the hamstrings. So automatically we're affecting the muscles above and below, just even with rotational movement itself.
Yep.
So it kills like 3 birds with 1 stone kind of deal.
And I see you have the popliteus muscle highlighted. That is a muscle that I will eventually check if their knee pain isn't improving. And I find that one to be sometimes deconditioned. And I start to improve that muscle, and it does seem to help improve the knee as well.
And that one controls locking and unlocking the knee. So is there certain things that you do in terms of have them straighten the knee, you hold resistance, and you have them try to bend?
Yeah, so I'll use my arm as the knee here, but as they're on their stomach, what it helps us do is it is a flexor of the knee, and it can also help, I believe it's a internal rotator. Yeah, it is internal, because that's what I have them do. I have them flex and then internally rotate, and then I try to externally rotate the foot, and I try to extend the knee. And I'm testing basically that posterior.
I see.
A lot of more, probably parts of the hamstring too, but it's also getting popliteus in there. And if they don't have the ability to do that, then I do reciprocal inhibition with them. So I'm palpating and then improving stimulation of the popliteus while they externally rotate and extend.
Oh, gotcha.
The antagonists of that, as I'm palpating and stimulating muscle spindles, Golgi tendon organs, and then that reciprocal inhibition, we see a lot more stimulation there. I go retest, it's strong, and as I continue to help facilitate action potential of the popliteus, you'll see a little bit more stability, because again, like you said, it does help with the locking, unlocking. But I also feel like what it also thing that it does is it can be a guard for shearing of the femur against the tibia. And so when we do have ligament laxity, when we have a strong popliteal muscle, we see less of that shearing force when it is strong. And that's why I do sometimes see a need for improving the popliteal muscle.
Love that.
Yeah.
Ooh, that's exciting. So I'll add one other small one with the knee in addition to the popliteus. So we looked at the backside. Let's look at the front side, especially for basketball players. So the patellar tendon, how the quads, your front thigh muscles attach to the knee, the kneecap, and then from there attaches to the bottom part of the tibia. You want to eventually, and this is where toes or knee over toe work comes into play.
Yeah.
You want to stress that tendon as best as you possibly can by doing knee over toe work, whether it's you're putting your heel on a small platform and you're going down and doing squats, whether it's you're purposely trying to bring your knee over your toes in a rotational fashion. A lot of that will build up the strength of the quads, the front thigh muscles, and also help for kneecap for tracking as well.
That's awesome.
So,
I love that.
Add that into your everyday regimen from there.
Alrighty, guys. I think that is all we have for you today. We appreciate you guys listening. If this was valuable, please share it with anybody you'll the need to listen to this. Hopefully you are enjoying these core episodes where we're just diving into the gems. Let us know how this has been going, and we can always talk on any other episodes that you want us to do more short bits on. Until next time, guys, we'll see you soon. You have a wonderful day.
Woo!
Disclaimer, the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the functional code. Until next time, stay well, stay informed, and embrace the science of living well.